I'm a McMaster orthopedic surgeon. McMaster made up the word evidence-based medicine 30 years ago. We taught it to the rest of the world. We trained Dr. Bandari. If anybody, we should practice evidence-based medicine. I'm a spine surgeon. In my field, there's type 1A multi-million-dollar PRCTs that show us definitively that I should be treating all of my spinal cord injuries with megadose methylprednisolone. Neither of the two people who came into the Hamilton General last night got that. I should be treating all of my back pain patients with lumbar disc arthroplasty. Many of you know that I don't do much of that. I should be treating each and every lumbar insufficiency fracture I see and urine my grannies with kyphoplasty. I do very little of that. Why? That's why I give this talk. The reason I don't do much of those things is that the structural quality of most of the spine literature is an absolute cesspool. Completely flawed at outset, completely driven by business interest, and that's why it's so important for you guys to be here today, giving up a perfectly good day in the OR to waste your time in this research course. You need to understand that literature in ways I couldn't dream of at your stage. You need to be able to look beyond the studies. You need to understand the fundamentally important things in study structure, like what's our question? How do we answer it? Is the data analysis accurate and proper and independent, or maybe sometimes not? I've been in spine surgical practice for 22 years now, through the golden years, really, of spine surgical growth and development. We are only now starting to see type 1 evidence that's clean and proper come out in our field. A classical example you might want to quote of Canadian material, Canadian Journal of Surgery on my desk has a wonderful study of mortality around osteoporosis fractures. It's a multi-center, well-done piece that for the first time shows an incremental death rate from osteoporosis fractures in isolation. Makes a great argument for, my goodness, we should all treat osteoporosis aggressively. It's a fantastic study to look at, and after you read the whole thing and are convinced, read the disclosures. There's about 15 authors. Each and every one of those authors admits to being on the boards or payrolls of about 15 different companies, all of whom sell osteoporosis drugs. I'm not so sure I believe that study. I was a chief resident a little over 20 years ago, working with a guy named Joe Miller at McGill, who was an implant development surgeon for the Zimmer company. He developed several total knee arthroplasties, including their first Uncemented. At the time, arthroplasty was a relatively young technology. Total hips had been done for about 20 years, total knees for about 10, and there was a terrible clinical problem out there of peri-implant loosening and radiolucency going on. At the time, we thought it related to bone cement fixation. We called it cement disease, and there was all kinds of research and product development going on into improved cements or uncemented prostheses. Dr. Miller was developing an uncemented, the first uncemented total knee for Zimmer. At the time, the Dupuis company had been first into the marketplace with their uncemented PCA implants, selling at about $4,000 a unit. That's almost 4 times what we're paying in this day and age. Zimmer was pushing madly to compete in the marketplace. Healthcare, remember, is a business. And they decided to improve their prostheses by changing the usually white plastic liners to a horribly sexy, shiny black thing that was impregnated with carbon fiber. Doesn't that sound great? It sure did at the meetings I went to. They were abominable. The first generation uncemented total hips from Zimmer had a 55% revision rate at 2 years because the basic structural design in the femoral stem was so bad. The hips, the knees eroded very, very quickly because that harder black shiny cement or plastic was brittle, and it fell apart and caused a massive synovitis very quickly. We hurt a lot of patients by bringing implants into the marketplace that really hadn't been studied at all. We have protocol for studying technologies and releasing them into the marketplace. Driven by the states with the FDA, driven largely by the thalidomide crisis of the 60s and 70s. Thalidomide, some of you probably know, is a drug that was sold to help with peripartum nausea and vomiting for mothers. It caused terrible limb malformations in the children. There are three types of drugs or devices in the American protocol. Canada doesn't have our own shtick. We piggyback on the states. A type 1 drug or implant is an old technology, say hydrochlorothiazide for hypertension or a bone screw for fixing a fracture. You can make that, sell that, nobody really cares about it too much. A type 2 technology is an old thing for new application, maybe using hydrochlorothiazide to treat swelling of the feet, or a bone screw or a fracture bone screw to fix something in the spine. And a type 3 technology is something that's really new. And that's where the big studies come out. If you want to bring a new medical or implant technology into the marketplace, there's a hugely complicated protocol for studying it and allegedly determining that it's safe. And companies routinely spend 7, 8, 9 figures in those studies. Those guidelines are supposed to protect us. Thalidomide's been off the marketplace for 30 years, but it's coming back. It's interesting. This terrible, terrible drug that we know has hurt so many people and babies is being resold into the marketplace to try to help with the nausea and vomiting of chemotherapy. It's a little scary. Just in the course of my career life, any number of cure-all spine technologies have come and gone in the marketplace. I started on the tail end of chymopapane and discase, which were percutaneous injections for disc hernia that saved the patient needing a surgery altogether. The nucleotome was a percutaneous suction aspiration device. We've had an arthroscopic discectomy. We have infused bone morphogenic protein to help with our spine and fracture fusions. Medtronic spent $600 million developing that product and bringing it through the FDA. Unbelievable. Nobody thought that they'd ever go anywhere with it. They made up their costs in the first 10 months of sales. Minimally invasive spine surgery has been big in the marketplace for well over a decade now. Motion preservation technologies, we have 4 different alternatives in spine care now that will help you stabilize the spine without fusing it. None of those technologies are really worth the paper that they're printed on. One such is the high-dose steroids for spinal cord injuries. There are 4 different NASCIS studies. NASCIS stands for National Acute Spinal Cord Injury Survey. They're NIH and FDA-backed studies to try to look at chemical prophylaxis of neurological deterioration after blunt trauma. NASCIS 2 was analyzed and presented as showing a positive result. Here's a drug protocol for methylprednisolone that's going to minimize or sometimes prevent neurological deterioration after spine trauma. Fantastic. When the data was analyzed, the authors went to New England Journal and said, look, we've got to put this out as soon as we can. New England Journal agreed and said, next edition, it's coming into print. It takes 3 weeks to go from deciding what the final print is going to be to having the journal out there in the world. So NIH funding the study, the New England Journal editorial board, the study authors said, wait a minute, if we don't get it out quick, then everybody who gets neurologically compromised over the next 3 weeks can sue us, because we knew they could have been protected. So NIH did a funny thing. They said, all right, we need to get this information out right now, and they sent an emergency fax to every U.S. physician in emergency room, said, use this drug. The drug is now standard of practice in the States. When you look at the study, in simple terms, it's garbage. It's a study of almost 500 patients, and the primary outcome from the primary analysis of the database says no benefit. You spend $10 million on a study, people funding you aren't very happy that way, so we did a post hoc analysis. We started analyzing subgroups, and they found a group of about 40 people where they could bring out a statistically significant benefit from using the drug. It was a 4-point motor index score affecting improvement in the patient's left arm. Statistically significant, therefore valid, therefore went into print. A post hoc analysis, you're going to learn, is meaningless and should probably never really be presented. Our literature does it all the time, but we know it's wrong. A 4-point motor index score improvement basically means the patient could twitch their left arm a little bit better than they could without the drug. It's nothing that was clinically important. So we had a statistically significant outcome that sells the drug, but we're not doing the patients really any good at all. And when you look at the downside, there are a lot of complications from megadose steroids. But none of the complications in the study hit statistical significance, so we convinced ourselves at the time that it wasn't important. 6 people bled to death from their ulcers. All kinds of infections and dural tears. There's more literature out there criticizing the methylprednisolone studies than there is on the methylprednisolone studies. Canada has led, particularly with John Hurlbert, who's a neurospine surgeon out of Calgary. These are only 2 of his publications on the topic. It's quite a tragedy for the spine care population. But our leaders let it happen. The NIH let it happen. The editorial board of the New England Journal let it happen. So you need to be better. In a few years, you're going to be on study boards. You're going to be editing journals. You're going to be participating in study designs. Don't make the mistakes of the past.